to the room. All right, we'll get started. Good morning and welcome back to our second webinar in our four-part webinar series focusing on value-based care. My name is Josh Miller and I'm the project manager for the Northern Border Region Technical Assistance Center, a program overseen by the Rural Health Redesign Center. Also with me is my colleague, Tom Harlow, project director of the Northern Border Region Technical Assistance Center. In today's webinar, we will be learning more on lessons learned from a global budget demonstration through the Pennsylvania Rural Health Model. Before we get in today's presentation, I want to address two housekeeping items. First, please mark your calendars for next month's webinar, which will be a panelist discussion focusing on accountable care organizations. This webinar will take place on Tuesday, June 6th from 10:30 a.m. to 11:30 a.m. Secondly, we encourage participants to actively engage in today's discussion by directing their questions in the Q&A section. My colleague, Tom, will help with this. We will strive to address every question, and for those we may not have time to answer, rest assured that they will be addressed when we put this webinar recording out there and to our CVent site. And now it gives me great pleasure to introduce our incredible speaker for today's webinar, Janice Walters. Janice is the Chief Operating Officer of the Rural Health Redesign Center, the RHRC, where she has been spearheading rural health transformation efforts since May 2020. Janice's incredible dedication to rural health is evident in her role leading the Pennsylvania Rural Health Model since 2018. As a driving force behind the model's implementation, she has been instrumental in recruiting stakeholders, developing methodology, crafting transformation plans, and overseeing technical partners. Currently, she is also serving as a project officer for both the Northern Border Region Technical Assistance Center, which is where this webinar series is being supported through, and the Rural Emergency Hospital Technical Assistance Center, both projects that the RHRC oversees. Before her impactful work in rural health transformation, Janice spent 12 years in healthcare leadership positions, primarily in rural Pennsylvania. Her diverse experience spans financial oversight of rural health systems, business activities, population health initiatives, the communication industry, and manufacturing. A very dynamic background. Janice's strong educational foundation includes a Master's of Science in Healthcare Administration and 2 undergraduate degrees. We are truly privileged to have such an accomplished, dedicated, and passionate leader share her insights with us today. Without further ado, Janice Walters.
Thank you so much, Josh. I certainly am passionate about rural health. I do, as I like to say to other folks, it is my calling in life and something that I am very, very passionate about and really do feel privileged to lead such meaningful work, not only within the state of Pennsylvania, but now across the country. So our goal today is to really provide a bit of insight into the Pennsylvania Rural Health Model. It is a program, as Josh mentioned, as part of my bio that I've been leading since 2018, but really would like this to be as engaging as possible. So if you do have questions, certainly in working with my team, Tom and Josh here, we will try to make this as meaningful as possible for you folks today. So if you have questions, please do put them in the chat, and we will make this as conversational as possible in order for you to learn from our experiences within the Pennsylvania Rural Health Model. So really my goal today is to, again, lead a conversation and really, again, provide an overview of the Pennsylvania Rural Health Model, otherwise known as PARM, our acronym PARH reach them. Really sharing with you what it is and its overall goals, showing you how we've been able to scale the program across the state of Pennsylvania, provide insights into the very principles of the program, as well as the value-based transformation, and then certainly provide learnings along the way. As with anything new, this journey has been ripe for learning in terms of what works within rural health innovation and where there have been some challenges. And as I speak about our program publicly, I'm the first to say our program is not perfect, but we certainly feel it was a great starting point to start and try to test something new to address the rural health closures across the country. And we really do feel like we are achieving our mission of keeping rural hospitals more sustainable. So really at the highest level, what is the Pennsylvania rural health model? What is it and what are we trying to achieve and how we are going to measure success? So that was all part of the vision as Penn was put to paper back in 2016 and actually 2015 and 2016 to start visioning of what this program actually could mean. There were some overarching goals that we were trying to achieve and measurement identified in terms of how we're going to measure success. And so first and foremost, we're testing an alternative payment arrangement for rural hospitals to see if we fundamentally change how rural hospitals are paid, can we actually provide a more stable financial position for our participant hospitals over time? So that's goal number one, to actually see if we can sustain rural hospitals over time through a fundamentally different way of paying them. Secondly, we want to see if we can actually improve the population health of the residents in these communities that are served by these hospitals. And so we're trying to achieve a few overarching goals, which is increase access to care, actually improve chronic disease management and preventative screening. So can we improve the health of the population served in these communities through increased preventative screenings, increased access to care. And then we're also trying to reduce deaths associated with substance use disorders. So much like the rest of the country, certainly communities in the state of Pennsylvania within the rural health model, we now have data to show we are serving some of the most disparate populations in the state. And I'll show that information in some future slides, but really, can we improve the health of these populations? And then, of course, reduce the total cost of care over time? Can we actually impact the growth curve over time and achieve savings? So they are at the heart what we're trying to achieve through the Pennsylvania Rural Health Model Program. As it relates to scale, I have spoke about this program for several years now, but certainly, we now have a picture of the scale across the state as it relates to our participant hospitals. So we are currently working with 18 communities across the Commonwealth, being spearheaded by the hospitals in those communities. So we were able to recruit 18 participant hospitals that voluntarily raised their hand to say we want to test something different to actually see if we can bring more sustainability to rural health care through this demonstration program. So wherever there is blue on this map, whether it is a dark blue or a light blue, means that there are populations that are being impacted by our program because we are working with the hospitals where they receive care. So any place there's blue on this map, it means there is somebody that resides in that area of the state that is actually receiving care from one of our participant hospitals. And like a lot of rural communities, this map certainly represents that in rural communities, rural Pennsylvania not being any different, patients drive to receive care at hospitals. And so you can see there's quite a bit of geography where our hospitals tend to be more in the center of the dark blue, and then people drive sometimes great distances to receive their care from the rural hospital. So again, this is a map that just shows that sometimes a picture is worth 1,000 words, and this shows the impact of our program across the state. We estimate that about 1.3 million Pennsylvanians reside in the participant communities, and we have over 1 million covered lives within the program. So it is an all-payer program. So not only do we work with Medicare, fee-for-service, traditional Medicare fee-for-service, but we're also working with all of the dominant payers in the state of Pennsylvania. So that includes our Highmark Blue Cross Blue Shield program within the state. It includes Geisinger Health Plan. It includes UPMC Health Plan, as well as Aetna. So it really is an all-payer program. We have both Medicare, managed care programs in our plan, as well as Medicaid, MCOs, and commercial members in our program. And so again, over 1 million covered lives reside in these communities, and our hospitals are paid an alternative payment arrangement for the care they provide. And I'll get into a little bit more detail there as well. So again, I like to say, now that we know the denominator, now that we know that blue area of the Commonwealth that we are supporting through our program, it's allowed us to do some deep dives into the demographics of those communities. And it's not surprising to see that our program is in some of the most disparate populations in the state of Pennsylvania. And so we've got higher disability rates, poverty rates, and unemployment rates within our community on average. And also, not surprising, most of our hospitals are also the largest employers in their communities. And so making sure that these organizations stay open is very, very important, because the starting point for these health outcomes is actually with these hospitals open. And certainly if these hospitals were to close, the health disparities and inequities in our rural communities would only worsen. And so again, going back to the overarching goal of the goals of what we're trying to achieve is certainly keeping these hospitals open and really improving the health of these communities through increased access to care. So not only are some of the social indicators showing that our communities are poorer than average within the state, and even rural averages, it's not surprising that we have increased death rates associated to chronic disease. So lung cancer death rates that exceed averages, heart disease death rates, diabetes death rates, etc. So we truly are in some of the most at-risk communities within the Commonwealth, and really trying to sustain healthcare in these communities. So again, data conclusions show that these hospitals remaining in their communities is essential. And so, part of our work is to work in partnership with our participant hospitals through the core principles of our program, which I'll get into in a little bit more detail in coming slides. But it really is to improve the population health of the residents of these communities. Currently, the starting point actually shows, decreased population health outcomes, I should say, because we do have higher employment rates, higher poverty rates, higher barriers to access to care. And of course, our hospitals have much less resources than some of their urban counterparts. And so that's where we can step in as the Rural Health Redesign Center and really help position our hospitals for success by providing them technical assistance in order to prepare them for success within this new payment arrangement that they would not be able to afford elsewhere. So again, that's just a picture of, I would say, the communities, our program, what we've been able to build as it relates to a program footprint. And now I want to explain a little bit about the specifics of the Pennsylvania Rural Health Model specifically. So really the model offers at the highest level what I like to call value propositions from both a provider and payer perspective. So certainly whenever we're trying to test anything new from a stakeholder engagement perspective, we understand that we have to, I like to say, identify the WIFM. What's in it for me in order to get folks to want to engage on something new? So even though we know the current fee-for-service environment, it may not be sustainable, we also know that change is very, very hard. And we also know that the foundation of what makes all of this work is trust. And so part of that trust as it relates to stakeholder engagement is really getting out into the community and making sure folks understand what we are trying to achieve, why we're trying to achieve it, and again, identifying the WIFM. So really this slide and the next slide identify the key things that we needed to identify and have a direct communication with both our payer and provider community to identify the value proposition for each one of those stakeholders. So certainly we all understand the current fee-for-service environment is not sustainable, given the unpredictable revenue trends tied to fee-for-service and the risk that produces for our rural communities. And certainly the desired future state is a predictable revenue stream, and how the program, the model actually supported that desired future state. Certainly, we know that significant volume is being driven by potentially avoidable utilization. And so the desired future state is being able to provide the right care for the patient in the right setting, but recognizing that our current payment arrangement does not necessarily produce that win-win for the patient and the hospital, because they certainly need the payment to stay open. And so we certainly believed that value proposition number 2 is it aligned the population health as well as the payment, the need for payment reform. We also recognize that a lot of our utilization in rural communities is lost to tertiary centers. And within the Pennsylvania Rural Health Model, hospitals can actually grow and bring utilization back. So our methodology is flexible enough to actually allow hospitals to bring appropriate utilization back to the rural hospital. And certainly, value proposition number 4 was making significant investment in population health already. We certainly know in some rural communities, this is the case in Pennsylvania, there was a lot of value-based work already happening, but it was being bolted onto the fee-for-service payment system. And so even those incentives were then tied on, attached to volume. And so certainly we believe the value, the desired future state is to slow the bleeding from the current fee-for-service model that occurs when population health investments are made within the fee-for-service model. Again, because fee-for-service is all about volume. And so it's really, really hard for small hospitals, to reduce their fee-for-service utilization when much needed payment was tied to that. And so again, a value proposition that allowed hospitals to engage. Value proposition number 5, the current scenario was the hospital may feel like an island unto themselves for strategy development, especially if you're an independent rural hospital out there. Sometimes you might not have those larger partners, but through our program, it's really created a collaborative environment of our 18 hospitals and the ability to learn from each other. Key learning of our work is this value proposition number 5 has actually been one of the most worthwhile things that we've been able to create for our participant hospitals. We like to call it the cohort experience, where you actually get to embrace with people that are on a similar journey and learn from each other within a safe space. So key learning, this cohort experience number 5 has been one of the most probably talked about benefits of our participant community. Obviously, lack of technical resources. We offer through the RHRC robust technical resource infrastructure to support our hospitals on this new journey. And then certainly stifled innovation. And again, within the program, we've been able to provide some flexibilities to our hospitals to test innovation in a safe space within a payment model. So again, they're the things that we like to call the WIFMs. What did we use to recruit hospitals and payers? Certainly, we had to identify the value proposition of what was in it for that hospital. And of course, fundamentally, the math had to work. We had to be able to prove to our hospitals that they would be better off in the program within the alternative payment arrangement than without. And so certainly step one or two, education, and then identifying if the math works is fundamental to being able to grow participation and engage with folks. So really at the highest level, I like to say our program has 2 pillars. Each pillar is equally important in my mind. The first obviously is the payment mechanism, which is the hospital global budget. And that's the portion of the program that really looks to stabilize the cash flow from all of our participant payers to our participant hospitals. It's really the funding mechanism to the program that actually actually allows for the second pillar of the program to be realized. And that second pillar, again, is equally important. It is the transformation plan. And so we have a global budget, and in exchange for that global budget, our hospitals are asked to commit to moving to a value-based delivery system through a transformation planning process where we actually ask our hospitals to identify 3 things that they're going to work on each year. Some of these are short-term and some of them are longer-term goals where they're going to begin to invest in population health and wellness. Because actually in our program, the hospital is not harmed if they actually improve the population health of the community they serve. So this next slide is representative of really what at the highest level, the Pennsylvania Rural Health Model is looking to do. On the left-hand side of the diagram is really the current fee-for-service environment, that as utilization decreases, hospitals' revenue decreases. And so again, if you're in a value-based arrangement that is tied to fee-for-service, for every time that hospital or that patient does not come into your hospital, your revenue could be influenced by that. And within the ACO framework, which there is some promise within the ACO framework, the balancing act is to make sure that there's enough value from that ACO framework to offset the decrease in utilization, because if there is not an offset, actually the hospital could risk revenue by improving the health of the population. So it's very much a balancing act specific to the hospital within that ACO framework. Within the global budget, we're actually, again, using historical revenue, and that has been a criticism of our program, that we did start with historical revenue. Again, we recognize it wasn't perfect, but it was a starting point to actually start the journey. But we calculated a global budget, and then we've said to the hospitals, if you improve the health of the community and they don't simply go someplace else for their care, you get to retain the revenue associated with that historical utilization, even though the patients may not need that care. Your global budget, as long as you're keeping folks out of the hospital, and again, that they're just not migrating somewhere else, you actually get to keep that revenue in your global budget. So it reduces the risk, eliminates the risk of actually jumping into population health with both feet, because you're no longer at risk for losing revenue if you actually keep people out of your emergency room or out of your hospital. So at the highest level, we are different than Maryland, and I do like to draw that Maryland is also functioning in a global budget framework from a state perspective, but they have some unique factors that allow them to do that within the state of Maryland. They have what's called rate setting. And so there's an organization that actually sets the rates for all of the hospitals in Maryland. And so the global budgets are really, I would say, built at the highest level and then pushed down, where we had to take a different approach because we don't have rate setting. Ours is a voluntary program, and so we had to recruit our hospitals to the program. And so we actually have to build the global budget one payer at a time. And so we work with, again, all of the participant payers that we have, and we do have all of the prominent payers in the state with all of their products. So if they've got commercial, if they've got Medicaid, and they've got Medicare, products in these communities, we work with them to build a global budget across all of the program, all of the payers, all of the products, and the aggregate of each of those individual global budgets becomes the hospital's global budget. So we had to take a bottom-up approach in terms of building the global budget for our hospital, which does make us different from Maryland. And also, we are specifically focusing on rural populations in the state of Pennsylvania versus a state approach where all hospitals are participating. Ours is a voluntary program, which does make us different as well. So that's how we build the global budget. We do some adjustments. So one of the questions as I was recruiting hospitals, I would get, well, what if I can grow my utilization? There is the ability to flex the global budget. And so we do some adjustments semi-annually, and then we have other annual adjustments. And so in the state of Pennsylvania, Pennsylvania, we have a highly competitive insurance marketplace. And so we have a lot of different payers in our community selling their products, whether that's commercial or Medicare. And then we also had a state rebid for the Medicaid MCO products in the state, and who would be serving our Medicaid subscribers within these communities. And so we had to build in payer mix fluctuations so that if a payer grew their membership, our global budget could flex, and conversely, if they lost membership, their global budgets could go down. And so we're looking at payer mix twice a year. And then we also do adjustments for things like unit price adjustments, inflationary factors, unplanned volume shift, because people in the United States still have choice. They have free will. They can choose to receive their care wherever they would like to go. And so to the extent that if they choose not to seek care at the participant hospital, but rather go somewhere else, the global budget can go up or down depending on how the community is responding to the local hospital. We certainly do demographic shifts for Medicare. And then also we do have some savings targets as it relates to reducing avoidable utilization. And so we've set some targets out there. There is some, we like to call them haircuts in the global budget for portions of based on those targets that we've established. But if the hospitals actually do better than their target, they actually get to keep that benefit in excess of the target in their global budget. And then certainly when this program was envisioned, nobody could see a pandemic coming. But certainly we did have flexibilities within our language that allowed us to do some adjustments and exceptions to the methodology based on the exogenous factor changes that might have been needed. And so again, that was written in to the program back in 2018, but certainly we did execute that flexibility within the midst of the COVID pandemic. So really at the heart, our program is really incentivizing hospitals to really focus on the avoidable utilization coming into their organizations and building better outpatient infrastructure by which to keep people out of the hospital. So again, when you don't have to worry about your revenue, it's really allowed our hospitals to embrace, population health. One of our CEOs, when he came into the program, said for the first time he felt he was brought to the table as a partner within the value-based journey versus being treated as a cost center, because we certainly know that hospital cost is often the largest contributor to healthcare expense. And so really reducing avoidable utilization, but we certainly do recognize that making sure our hospitals stay open in rural communities is very much needed because there are patients that need hospital care. And so really we're asking our hospitals through the use of data to identify the avoidable utilization coming into their hospital to reduce it, with the long-term goal of then being able to have our hospitals reinvest in community health and wellness programs that with the goal of the global budget being able to be the sustainability for those factors long term. And so as utilization goes down, but hospitals retain the revenue in the global budget, the long-term goal is to then have them reinvesting in community health and wellness through the global budget. Now, again, full transparency, given the pandemic, the impact, and now certainly functioning in this very high inflationary period, that we're currently experiencing, the reinvestment of our hospitals in these types of programs has been slowed because certainly they're needing the global budget to just manage through the inflationary environment that they're currently experiencing. But certainly our program, probably the biggest thing that we have, as a success story is that all of our hospitals did remain open during the pandemic, and certainly a lot of them will attest to this program as being the means by which they were able to stay open. But at the highest level, this is really what we're trying to achieve within the confines of the Pennsylvania Rural Health Program. Also, just giving you insight into what does it mean to transform? What are our hospitals actually doing on the transformative journey? What does that actually mean? And so this is just a really high level picture of the areas that our hospitals are investing in specific to transformation. Most of them are launching some type of a care management program. That's been a lot of the efforts in terms of, historically in the hospital setting, care management really was about discharge planning. When the patient was getting ready to go home, making sure that they had all of the resources that they needed to be successful post-discharge. We really believe in the population health space. This is a perfect opportunity for hospitals to step in and do some actual chronic disease management, especially for the traditional Medicare populations that might not have this service being provided to them through commercial MCOs. And so really working with our hospitals, teaching them skill sets of how to even identify who could benefit from a care management program. I think there's some, again, key learning. I think there's some misconceptions out there that because a hospital bills and has the revenue cycle data or the billing data that's submitted to the insurance providers, that, well, they have the data that they need to do population health and wellness. I will tell you, most hospital billing systems are not built to do population health type of reporting and identification of needs. And so again, us working with them through the Rural Health Redesign Center to really work with them to help to identify the patients that could actually benefit from these types of programs. We do use billing data, but again, we have some pretty robust data analytics skill here at the Rural Health Redesign Center that's allowed us to do this, recognizing that most small rural hospitals are not afforded the ability to have those types of resources on their staff, given the current financial infrastructure, the payment system. It just does not afford them to have those resources on staff. Certainly, we're also helping them identify opportunities specific to ED utilization. So again, if you go back to the goals and providing the right care in the right setting and reducing avoidable utilization, helping organizations understand their ED utilization, helping them build basic patient registries to identify the folks that are coming into their organization, again, that could benefit from more robust outpatient systems. And then certainly, substance use, behavioral health, working with our hospitals across the program to really introduce some infrastructure that we think will benefit all of them, but helping from a central perspective, how do we actually create that infrastructure to help address some of these broader needs that we know are in every community. So hopefully that helps you visualize when we say transformation, what does it actually mean? We are very practical and pragmatic people. I'm a firm believer in small incremental changes over time will yield very, very impactful outcomes. And so working with our hospitals, again, to learn new competencies that are not necessarily embraced or come naturally in the fee-for-service. It requires different mindsets. It requires different tools. And we here at the Rural Health Redesign Center try to provide that support to our hospitals. So the value of PARM, really quickly, just want to touch on, what are some of the value that we've seen in the program. So we do like to share this independent study that was done by our hospital association here within the state of Pennsylvania, and looking at our 18 participant communities to really identify the value of the program. And so if you go back to really the demographic information of our participant communities, we certainly recognize that we have a lot of health disparities already. And as I've mentioned, keeping these hospitals open is so important. So not only for the health care that these organizations provide, but also to the economic benefit that these organizations bring to the state of Pennsylvania. Through first, second, and third dollar spend, it's been identified that these 18 hospitals yield $2.4 billion of economic benefit to the state of Pennsylvania into their communities. And so, again, sustaining these organizations, not only for the healthcare that they provide, but also for the economic. Oftentimes, our hospitals, and again, this is not unique to the state of Pennsylvania, oftentimes the rural hospital is one of the largest employers within that community. In ours, we're usually one of the top 2 or top 3. Some of our communities, they are the number 1 employer in the community. And so not only if that organization closes, not only is healthcare lost, but certainly the economic viability of that organization is also, of the community, is also impacted. And certainly we see that across the country as rural hospitals close. So again, the value of PARM is, the Pennsylvania Rural Health Model is working to keep these hospitals open to ensure the jobs stay in the community as well as the health care that they provide. And again, we're asking our hospitals to really serve as the convener. We recognize they can't do all of the population health and wellness on their own, but really serve as the convener to bring community resources together to advance and improve population health within the participant community. We do have good data to show from a Medicare perspective as it relates to, PQI quality measures out there. As we look at year-over-year changes within our PQI, quality indicators, looking at specific ambulatory sensitive conditions that lead to hospital stays, we see favorable trending in that we have been able to reduce avoidable utilization and using, again, standard quality programs that are out there, not looking to reinvent the wheel within our program, because, again, we certainly understand that rural hospitals are strapped with resources. So looking to use current quality programs, current measurement that's out there to measure the impact of our program. I'm also not naive to the fact that we were running this program, during the height of the COVID pandemic. And so certainly some of the pandemic could be influencing some of this data, some of these data points, but, the data is the data. And so again, showing very favorable trending as it relates to reducing avoidable utilization from a quality of care perspective for the residents of our communities. Again, just another very busy slide, but really, again, showing you that from, overall trending of avoidable utilization within the ED, the all-payer inpatient readmission rate, and all-payer inpatient ambulatory sensitive condition rates, trading favorably across all of the different cohorts. So we actually onboarded hospitals for 3 years. The cohort determines what year they joined the program. Cohort 1 joined in 2019, cohort 2 in 2020, and cohort 3 in 2021. But across all the cohorts, across all of the payers, there is certainly favorable trending as it relates to reducing avoidable utilization. So certainly counting this as the value of the Pennsylvania Rural Health Program. So certainly, data supports that the transformation processes are impacting avoidable utilization at our participant hospitals. And so as we continue to evolve the program, our goal certainly is to continue with increased transformation planning to decrease avoidable utilization. But certainly, we recognize that, ongoing, visioning is also needed. Key learning from the program is if your state or your organization is interested in being part of a journey like this, it is very, very important to have a shared vision at the very beginning to ensure that everyone is aligned in terms of what you're trying to achieve. This is something that we continually have to revisit in our program because, it's a very technical program. There's a lot of noise, but every so often we have to come back to the very vision and remind everyone, what are we trying to achieve? What are the goals? Just to make sure that everyone continues to move forward in the right direction. And certainly clear and direct communication, meaningful communication is very, very important. And then practical application. And it really is a cycle of ongoing collaboration, effective planning, then tactical application to increase results. We've got one more slide, I believe, Tom, and then I'm going to take your question. So really, where are we at from our program perspective? We certainly want to continue to advance this into a next generation program. As I recruited hospitals, I inevitably got the question, what happens in 2025? And so our goal is certainly to make sure that as we come to the completion of our current program, we continue to talk about the future. Most of our hospitals have really come to rely on their global budget, the predictability of payment that it provides them, because we do pay those global budgets on periodic installments that folks can count on. So really, as we continue to look towards the future, it's ongoing collaboration of healthcare providers, health insurers, partner organizations, and government, because none of this can really be done in a vacuum. It takes all stakeholders across the continuum in order to continue the momentum to drive innovative change within the state of Pennsylvania. And then certainly part of our mission and vision all along has been to serve as a learning lab for the rest of the country, so that we can take our learnings, share with all of you through sessions much like today, as well as then individual engagement. But we really are here to advance rural health innovation, not only within the state of Pennsylvania, but truly across the country. A couple key messages, and then I believe we're to questions, but really change is hard. Even though the current environment does not necessarily produce a sustainable path forward, it is really hard to change. And we fully grasp that, how difficult decisions might be needed at the board of directors. It requires different mindsets, overcoming fear of change. And as I said, even when rural health leaders know that the current is not sustainable, oftentimes they don't have the wherewithal or the time and resources to take on the change that is needed. And certainly data is essential. You can't do this without data. And so identifying your data sources early is very important. So Tom, I'm going to pause.
Yeah, great, Janice. Thanks. Really a lot of content in a short period of time. We have a couple questions. And again, if folks have other questions, please, if you could type them into the Q&A at the bottom of your screen. Janice, the first question, what are some examples of the recommended ways that hospitals would reinvest parts of their budget for community/population health?
Yeah, sure. So we're again trying to take very practical and pragmatic approaches. And so one of the places that we're seeing hospitals step into is in the area of food insecurity. And, we are encouraging our hospitals to implement social determinant of health screening. So again, really getting at things that impact a patient's health beyond the health care they receive from their providers. And so we certainly know that CMS is moving into that space and is going to, require providers to start doing some social determinant of health screenings. We've been encouraging our community or our participant community to do that since 2018. We really can't help folks if we don't ask basic questions. And so really teaching our hospitals, it's one thing to look at high level data, but in order to actually impact your community, you need to identify the who that needs help. So really, we're looking specifically at food insecurity, and then transportation is another area that we're really looking at. And then investment in outpatient services such as COPD. Pulmonary rehab was another big one that our hospitals, COPD seemed to be one of the driving causes. Again, not a shocker to anyone, but COPD seemed to be a driving cause of readmissions or ambulatory sensitive conditions. And so we did see a number of our hospitals invest in pulmonary rehab programs. We know in the fee-for-service space, pulmonary rehab is not well reimbursed. And so the value proposition might not be there in fee-for-service, but in a value-based, a global budget, if you can keep that patient out of the hospital and healthy, obviously quality of care is really, really important. But pulmonary rehab. So they're very two, I would say, food insecurity from a social determinants of health, partnering with food banks. Some of our hospitals even launched their own food insecurity programs. And then pulmonary rehab would be two very practical areas that we saw our hospitals engage in.
Thank you, Janice. We have a couple more questions. Next one, Kate is asking, would you explain a bit about how you got started? There was CMMI upfront investment, if I recall correctly. How did that work? Who is now paying the hospitals the global amounts?
Great question. So I'm going to start with the last part of the question first in terms of who is paying the global budgets. So the hospitals continue and always have received their global budgets from the payers. So none of the money that came from CMMI was actually used to pay the hospitals the global budgets. The payers have continued to remain the funding source of hospital revenue. What we built was the methodology here within the Rural Health Redesign Center of how those global budgets would be calculated across the program. Certainly CMS has reserved the right to govern the Medicare portion of the methodology. We have an independent board of directors that was created to govern the MCO or commercial aspects of the program. But we have tried to keep those lockstep as much as possible so that it's really, a common methodology that's used across the program. And so the money, the CMMI seed money, you are absolutely right. We did receive some CMMI seed money to actually start this program. But that really went to, again, the technical assistance to build the methodology, actually develop the methodology by which we calculate the global budgets. But then also provide technical assistance to both our hospital and payer community as it relates to doing this work. So again, fee for service, that infrastructure does not necessarily equip either payers or hospital providers to do this type of work. And so we've worked with our hospitals to help them understand their global budgets. We serve to combine all of the MCO aspects of the program so that they're not getting all of these different files. We really have built a streamlined process for all of the global budget work. And then, and again, that support is for payers and hospitals. And then we also work closely with our hospitals to develop their transformation plans. So the money that we got from CMMI was really to provide the technical assistance. That funding was for a limited duration. We certainly are no longer functioning under CMMI funding, but using alternative revenue now to fund the work here at the Rural Health Redesign Center.
Janice, I'm going to jump ahead to a question that ties in, I think, just to what you responded to. How did you get the commercial payers to the table initially?
So going back to one of the slides that I shared at the very beginning was finding the value proposition in terms of what's in it for them. So I'm not going to say it was necessarily easy, but certainly having the support of our state organizations, our Department of Health, our Department of Human Services, our insurance department, all of those organizations were really part of the visioning behind this back in the day. Again, aligning what the vision, what the mission was, and certainly sustaining access to rural healthcare is very, very, very important. Insurance companies cannot sell their product if they don't have healthcare providers, and that includes rural communities. And so again, identifying the value proposition for all stakeholders is fundamental, to program success like this. And so again, it really does take some thought there. And again, early stakeholder engagement. Nobody likes to be told what to do. But engaging people in that process, getting stakeholder engagement is essential early. And so I always ask when I'm, asked by other states, where to start, or we want to do this, two questions. Where's your hospital community? Do you have hospitals and providers at the table early on, as well as your payer community? Where are the payers? So they're two fundamental questions to ask very, very early on in order to get engagement, stakeholder buy-in, and again, identifying the value proposition for each of those stakeholders is essential.
Janice, your last slide that's up, you said change is hard. And here's, I think, a pertinent question. As you think about the leadership skills needed to best implement these changes, What leadership competencies are most important to effective visioning and a successful transition?
Thank you. So you're actually, I'm going to be speaking on some of these things, I think, in the last webinar that we're going to be hosting at the end of June. So whoever asked the question, please come back to that session, because certainly that's really, there's a lot to be said there. Certainly will do my best to answer that question today. But really, I think it's essential that you have folks on the team that have experience, lived experience. So I'm going to speak specific to rural, but for us to make sure that we had folks on the team with rural relevant experience as well. You know, if this is a hospital program, for us, it was ensuring that somebody with hospital experience, lived, breathed, walked experience is also part of the leadership, because that's essential to moving it forward. I think you have to have resiliency. This is very, very hard work. You have to have people that are passionate. You have to have a sense of humor. This work at the end of the day is very, very hard. And so you have to have that ability to laugh, because laughter is what has kept me sane for 5 years. And, you know, determination, and also recognizing that it's going to take a village. There's no one person with all the answers. And having the humility to say, I don't have the answer for you, but I will find the answer. And again, trust. I will say, you know, the basis of what makes all of this work is trust. It's the foundation that you have to trust the people that you're working with. And that, again, that everybody has that shared vision for the outcome that you're trying to achieve. Trust is hard to build, but easy to destroy. And having that knowledge. So again, off the top of my head, without my scripted slides in front of me to help answer that question, you know, they're the key components from a leadership perspective. You know, humility, sense of humor, resiliency, and really the ability, I would say, to facilitate stakeholder engagement and build that relationship of trust is paramount to success.
Thanks, Janice. We have several more questions, and I would just remind folks, if we don't get to your question that you've posted, we will answer it afterwards. Janice, the next question is just regarding global budgets for rural hospitals. Who or what determined them and pays them across 5 different payer categories?
So great question. So we, in our center, part of what we were tasked to do was build the methodology that would be applied consistently across the program. And so again, going back, part of the vision was to create an independent governing board that would oversee that methodology. That governing board is made up of equal representation between payer and providers. And so it was very, very important that it's a balanced approach to methodology development. You know, our board did an exceptional job. You know, some of the challenges that we had to, again, this is very, very hard work, and then throw a pandemic on top of it and trying to manage through a pandemic. And so that governing board, again, going back to the shared vision, the shared mission, what are we trying to achieve? You know, overall goal is to keep our rural hospitals open and sustainable. Really having that voice into the methodology development was essential. And again, it's applied consistently across all of the commercial or MCO aspects of the program. We've tried to keep it very much aligned with Medicare wherever possible. But the payment for the hospitals come from the payers through the methodology that we've developed. And that methodology included establishing the initial baseline budget. And so the initial baseline budget was actually created, again, using a historical view of what the hospital had been paid. And it was actually either the greater of the average of the last 3 years or the most current year, whichever was greater. So Lots of criticism. I've heard a lot of criticism, that you started from a historical perspective that didn't produce a viable path forward. How are they ever going to get to sustainability? I've heard it. We acknowledge it. We've recognized our program is not perfect, but we do believe it created a very good starting point, because, I'm a firm believer if we wait for perfect, we'll never get out of the starting gate.
Thank you, Janice. We're getting up on time, so we may have just time for one more question. And Janice, this question is, how are you engaging with primary care? Do all participating hospitals have primary care as part of their organization? Are there formal or informal arrangements between hospitals and primary care outside of the hospital organization?
Right. So that's a great question. About 50% of our participant hospitals employ primary care. And so it's different. Certainly for those that employ primary care, we feel through employment compensation contracts, you can align incentives. For those that, might not, it is, again, it's certainly an area that our hospitals are encouraged to engage with. We ask each of our hospitals to put together a stakeholder engagement plan where they identify the different partners in the community that they need to engage with. And so primary care is often identified as one of the partners. Probably one of the most, and I'll just offer it here, emergency room. Is where we've had some challenges because a lot of our rural emergency hospitals are covered by independent ED providers. And so certainly if that ED provider is paid on volume and we're looking to reduce volume, that can create some tension. But our hospitals have found ways to work through that. Certainly as part of a next generation program, we realize there needs to be more direct alignment with primary care than what maybe our current program does, because our current program was looking to stabilize the hospital specifically, and certainly recognizing where the rural hospital does employ the primary care provider, that if that hospital closes, primary care also leaves the region. So all that to say, yes, there is alignment in some of our organizations. More alignment is needed. We recognize that, and we'll certainly look to expand upon that in a next generation program.
All right, Janice, I'm going to challenge you. We have about 2 minutes left, and this is probably not an easy question or comment, but it is. So they are not really global budgets, just still mostly activity-based, but fee-for-service, smoothed over and paid over time.
So I would say no, that's not right. Because while the starting point was historical revenue based on fee for service, we do not rebase back to fee for service. We developed methodology that truly calculates and rolls forward the budget based on the adjustments that I shared prior. So at no point are we rebasing back to fee for service, because if we were, the answer would be correct. We're simply providing a different payment arrangement, but we are not just smoothing. The only exception I will make to that is for the critical access hospital. For the Medicare portion of the global budget, specifically for Medicare fee for service, they still are cost-based reimbursed. We have not interrupted that. And so that portion of the statement would be true, that we are paying the critical access hospital a predictable payment that ultimately does come back to cost, which we all know is fee for service. But outside of that example, we have divorced ourselves from rebasing, and it really is based on a methodology that we've developed in partnership together.
All right, Janice, we have one last question, so we're going to get through all these questions. Sophia asked, how is the global budget tied to quality outcomes? Will there be precautions to prevent undertreatment?
Absolutely. So that's part of the role that we play here at the Rural Health Redesign Center, is I like to use the term, make sure everyone remains good corporate citizens, and that, there isn't patient dumping. And so we actually are trending. We have outcome measures that we are on the hook to trend. They've been negotiated with CMMI. And so we trend that because we want to make sure that folks are still receiving the care that they need. That's also, if there is cost shifting, we can pick that up in our data. And certainly there as a risk in the global budget if we can see cost shifting, utilization going elsewhere. And so we've built mechanisms within our program that if something doesn't look quite right in the data, we do a deeper dive, because at the heart of it, we do need to make sure that no public harm comes as a result of this new model. And so certainly tracking quality, monitoring for quality is an essential component of our program as well.
Thank you, Janice. Really well done. A lot of content in a short period of time, and want to thank all of our participants. Our next session, as Josh had mentioned, is going to be on ACOs. It's a panel discussion, and that will be held on Tuesday, June 6th from 10:30 to 11:30. And then our last session is at the end of June, the 27th, I believe. So please, again, if you haven't registered for those, please do. We appreciate you joining. Thank you, Janice, for sharing today. And we're right up against time, and we look forward to seeing everybody next month on June 6th. Thanks very much, everyone.